Good evening, friends. Very warm welcome to the DBMCI MDS live sessions. Of course, we have our very own students who must be tuned in. I hope, right? And this is a session which is, I think, being broadcasted live on YouTube. So we have our other students as well. So, guys, I'm Dr. Aishvarya Kaushik, and I'm the faculty for dental materials as well as conservative dentistry and endodontics, guys. Now, today we are starting with our endodontics and conservative dentistry, and the first lecture, which is there for all of you, um, is going to be about endodontic diagnosis, guys, right? In terms of MCQs, concepts, practically, it's an extremely important topic. It comprises of your basics of your innervation of the tooth. So a lot of MCQs come from that. It comprises of your pulpal sensitivity, basically your pulp vitality tests, which in itself is very important from the perspective of endodontic diagnosis. And when you correlate it with other chapters like traumatology, endodontic traumatology, right? Uh, it becomes extremely important again. So it's that's why I always take this as the first topic. If you see your standard textbook like Cohen or even my textbook, we always put endodontic diagnosis as the one of the first few chapters in your textbook, guys. So without much delay, guys, let's start with our session. So we are starting with endodontic diagnosis. Guys, you'll find this chapter as diagnosis in endodontics in some of the textbooks, or endodontic diagnosis, and so on. Now, as I said, I always, because there are so many questions which are related to the innervation, C fibers, A delta fibers, proprioceptors, lack of proprioceptors, presence of proprioceptors, um, pulpal vitality tests, and everything is ultimately dependent on the tooth innervation, right, guys? So I always do the basic pain pathway, which apart from endo is of course coinciding with your oral medicine, with your oral and maxillofacial surgery. If you've had the good fortune of studying your local anesthesia in your oral surgery postings in your BDS final year from Monim, apart from Malamed, from Monim, you'll realize it's very much given in good detail. The pain pathway is very much given in very nice detail in your Monim. It's given in your Burkitt as well, and I feel it's essential, the base for the starting of an understanding of the topic of endodontic diagnosis. Of course, our students know this. In my lectures, I always couple my the information and the notes that we give. They're always coupled with the MCQs that have come in the previous 5 to 10 years. So that's going to be the model, or the pattern in which the lecture will be delivered to you guys, right? So we'll start with the pain pathway, guys. I'll talk about innervation as to which all are the nociceptors, what is the Erlanger and Gasser classification, what are the various MCQs. But first, we'll understand the basics of the pain pathway, guys. So we're starting with, say, the sagittal section. If you've seen your textbooks, it's a basic, very simple, sagittal section, or the side section of your, human head and neck area. And of course, we are dental surgeons, so we're going to talk about our teeth, right? So we're basically looking at these first order neurons, right, which are entering, or the apical foramen, right, from the central nervous system, essentially. So the first order neurons are coming from first a peripheral ganglion, right? Not a nucleus, but a ganglion, right? And where is that located? It's located in the middle cranial fossa. And please realize that this is not a part of your CNS. This is a peripheral ganglion. That's why it's known as the trigeminal ganglion, or also known as the Gesserian ganglion, right, guys? So that's my first order neurons, right? My first order neurons. And of course, we are most peripheral, right? In this entire pain pathway, as of now, we are most peripheral, right? So these are the peripheral, branches of the first order neurons. And also because this is the afferent nervous system, right? I'm talking of the sensory nervous system right now. I'm ultimately talking about the detection of the stimulus and ultimate perception of this stimulus as pain at the level of the cortex, right, in the CNS. So these are the peripheral afferents, right? That's very important, guys. These are the peripheral afferents, not the efferents. These are the peripheral afferents of the first order neurons, right? I'm going to be very conceptual here. I want all of you to understand this and memorize this simultaneously. So these are the first order neurons, the peripheral afferents of the first order neurons, which are going to have their cell bodies in this collection of cell bodies in the middle cranial fossa known as the Gesserian ganglion. If you remember your basic neuroanatomy, the collection of nerve cell bodies in the peripheral part of the nervous system is known as ganglion, and the central part of the nervous system, what is the central nervous system? The brain and spinal cord axis. It's known as the nucleus, right? So here we're talking of the ganglion because we are not yet in that central axis, right? We're still, we are there in the head, but not a part of that central axis of the brainstem and the spinal cord. We're going to go there, right? So we are in the trigeminal ganglion or the Gesserian ganglion, and these are my cell bodies, right? So I'm simplifying this diagram. And then, of course, I move centrally. I go centrally. So these are the central afferents, right? Central afferents. Again, the central afferents of, again, we are still at the first order neurons. First order neurons, right? And these are going to synapse where? These are now going to synapse in the CNS. Where in the CNS? Now that portion is known as, it's divided. That portion is divided into 3 nuclei, right? Where you're getting your innervation from the teeth and the surrounding periodontium. That's your nucleus oralis. Then we have nucleus interpolaris, and we have the nucleus caudalis. Now out of these 3 guys, it is the nucleus caudalis which is receiving the maximum number of central afferents of the first order neurons, right? So it is in this nucleus that we're getting the maximum bulk of our information, right? So that's my collection of, again, nerve cell bodies, right? And that is in the axis of the brainstem, the most caudal part of the brainstem, right? And from below this, of course, spinal cord starts. And this nucleus caudalis, because of its structural, its similarity to the structural organization of the dorsal part of the spinal cord, it's also known as the medullary dorsal horn, right? So as I said, we've entered the CNS now, right? Now what's going to happen? So that's my spectrum, or that's my trajectory of my first order neurons. We're still at the first order neurons, guys, right? Now I'm going to change sides. So all those neurons coming from the right side are going to shift to the left hand side, and vice versa. And now they're going to ascend in the form of your second order neurons to my another milestone, and that is thalamus. Right. Now this collection, before this, I just want to make one thing clear, guys. This collection of nucleus oralis interpolaris caudalis is known as the trigeminal nucleus. So please realize this. In the middle cranial fossa, we had the trigeminal or the Gasserian ganglion. And in the axis of the central nervous system, that's the most caudal part of the brainstem, right? We have the trigeminal nucleus, right? And the most caudal part of the trigeminal nucleus, right, the most inferior below part, is the nucleus caudalis, which is also known as the medullary dorsal horn, right, guys? All these are important MCQs. That's an important MCQ. The synonym of nucleus caudalis, medullary dorsal horn, the collection of all these nerve cell bodies in the CNS is known as the trigeminal nucleus. And as I said, it's going to change sides and it's going to ascend as the second order neuron, right? As the second order neuron, right? So basically, from where did it start? Trigeminal nucleus to the thalamus. So that's why the second order neuron path is also known as the trigeminothalamic tract. Guys, I'm not going into too much of details, right? Not into the messengers and everything. I just want you to basically have a understanding of what we're talking about. And then we move on to the pulpal sensitivity and sensibility tests, right? From the thalamus, these neurons are going to ascend further, right? So I'm going to put that in another color. They're going to ascend further right up to the cortex, guys, right? And these are the third order neurons, right? And this is known as the corticothalamic tract. So you have all these MCQs, guys, which can be asked obviously as part of endo, as part of oral medicine, as part of oral surgery. But ultimately, you end up solving all these MCQs in your exam, right? So the third order neurons are comprising, or the corticothalamic tract is represented by the ascending of the third order neurons from the thalamus to the cortex. Now, so essentially what is happening, guys, at the level of my tooth, what am I doing? I am detecting the painful stimulus or any stimulus, right? Detection, right? And some level of processing or modulation of this painful stimulus is going to take place in the trigeminal nucleus, more specifically the nucleus caudalis. So modulation or processing of this information is taking place right here. And finally, perception of pain takes place at the level of the somatosensory cortex, or simply the cortex, right? The cortex is also known as where the pain is perceived, the somatosensory cortex, guys, right? So we have these three kind of landmarks in the sense that how do you in three simple terms, how do you explain the pain pathway? That's your detection, modulation, and modulation or processing, and the perception of pain, right? Now the thing is, anatomically, what are these first order, second order, third order neurons? Now, guys, as far as the tooth is concerned, they are all either A delta fibers or C fibers. So when I'm talking of this entire spectrum of first order, second order, third order neurons, I'm basically essentially talking of the A delta fibers the A delta fibers and the C fibers. Right, guys? Now, first of all, because they are the sensory receptors for the pain, they are also known as nociceptors. Now, this is going to take care of one of the MCQs. The nociceptors are represented by, guys, there's a very big confusion sometimes that happens with all of us, that we think that nociceptors are only the C fibers. Both A delta and C fibers, both the A delta and C fibers are nociceptors, guys. In general, the pain of C fibers is more severe, probably giving to this rise to this misconception that C fibers are the ones which are responsible for the detection of pain, but it's also the A delta fibers, guys. Yes, the pain quality is different. It's less severe. It's lesser long lasting. Of course, we're going to discuss that subsequently now. But both A delta and C fibers are nociceptors. Also, another point of difference, that's your MCQ. Another point of difference is that in general, inside the tooth or inside the dentine pulp complex, if I may say so, the C fibers are in general greater in number. So the C fibers are in general 3 to 10 times more in number than the A delta fibers. Right. So this is another reason why probably there's this misconception that it's the C fibers which are nociceptors. They're all nociceptors, right? The next important MCQ is, why is it that all these sensations in the tooth are perceived as pain? Because primarily inside the tooth, you have only A delta and C fibers as far as sensory innervation is concerned. So that's why whatever stimulus you give to the tooth, it is going to be perceived as pain, right? Right, guys? Okay, fine. Next up is my MCQs from my next important subtopic here. Because we are talking of the A delta and C fibers, let us see where we stand. Where do these fit in? Where do these A delta and C fibers fit in the larger picture of things? Erlanger and Gasser classification Erlanger and Gasser classification of nerve fibers, guys, right? So in this, basically you have A, B, and primarily C, right? And within A, you have A alpha, you have A beta, you have A gamma, and you have A delta, right? Now within this, out of all these A fibers, listen to this very carefully, guys. Out of all the subdivisions of A fibers, the tooth has 90% delta, right? A delta. And only 10% of the A fibers are A beta, right? So primarily, this basically implies that we do not have A alpha, we practically don't have A gamma, we have some little amount of A beta, and we have a lot of A delta, right? And we have much more of C fibers than A delta, right? Again, B we practically don't have, right, guys? This brings me, so we've done this, we've done A delta and C fibers, which are the nociceptors. This brings me to the next important MCU, guys. Does the tooth provide you with proprioception? No. What are the main receptors which are responsible for proprioception? A alpha. A alpha is not there in the tooth. What are the second most important receptors which are responsible for proprioception? That's A beta, guys. And we have some amount of A beta, and that's also mostly located in the PDL, very less inside the tooth. Therefore, the applied MCQ, guys, is, so I'll solve 2-3 MCQs here with this one concept. The applied MCQ here is that even the pain, forget about reversible pulpitis, even the pain of symptomatic irreversible pulpitis in the initial stages is very tough to pinpoint or locate with your fingers because of the lack of proprioceptors in the dental pulp, right? So the pain of pulpitis in the initial stages is difficult to locate both by the patient as well as if you are only relying on your percussion test, right? To locate with percussion, because, and that's your MCQ, guys, because of and the answer is lack of proprioceptors in the tooth, right? And whatever proprioceptors are present, mostly they are present in your PDL, guys. And what are they? They are mostly your A beta. So they're mostly your A beta fibers, guys. So that's your next MCQ, that the proprioceptors of the tooth are the A beta fibers, and they're mostly located in the PDL. And that is why when the inflammatory mediators traverse the apical foramen, reach the PDL in advanced stages of symptomatic irreversible pulpitis, and of course in a necrotic tooth, right? Because your inflammatory mediators are now released by bacteria. In a necrotic tooth, the root canal is colonized by bacteria. So you have inflammatory mediators in the periapical tissues, in your acute alveolar abscess, in your pulpal necrosis, in your symptomatic apical periodontitis, in your advanced stages of symptomatic irreversible pulpitis. That is why it is only then that your tooth becomes sensitive or painful to the percussion test, and then only you're able to locate the isolating tooth. Otherwise, before that, you have to do other tests like the electric pulp test, cold test, and so on. Right, guys? So that's a whole 2-3, bunch of related MCQs that come from the concept of the lack of proprioceptors. Whatever proprioceptors there are, they are the A beta fibers, mostly A alpha is very less. They're mostly present in the PDL, very few in the dental pulp, right? Practically none. All right. Then we move on to the other important aspects, guys. When I talk of the A delta fibers, sorry, not this one. Yeah. This, guys, the A delta fibers, right? They are lightly myelinated, right? Let's do a comparative analysis of A delta and C versus C, right? And C fibers are unmyelinated, all right? They are A delta fibers have this, C fibers are primarily located inside the dental pulp, and A delta fibers move up, into the dentine up to a certain distance, right? So A delta fibers are going to traverse the dental pulp, and they're going to move up to a certain distance, guys. So that's my tooth. That's my pulp chamber continuing as the root canal in an anterior tooth. So I'm looking at, that's of course my enamel, that's my dentine. So I'm looking at my A delta fibers, which are going to enter the dentinal tubules, guys, right? Which are going to enter the dentinal tubules up to a certain distance. And what is that distance? That takes me to the next MCQ, guys. What is that distance? That distance is around 100 to 200 microns, guys. Right? So one reference writes 100 to 150, another reference writes 150 to 200. So the entire, you can say, inclusive of all the couple of references, they move up to a certain distance. Now, what happens is that because I'll move on to the concept of dentinal hypersensitivity and the controversy surrounding that very important MCQ about the laser, but in a while. But first, I want to finish the differences between the A delta versus the C fibers, guys. As I said, A delta fibers are the ones which are going to traverse the dental pulp and move up to a certain distance into the dentine, right? Whereas the C fibers are going to be located primarily in the core of the dental pulp, right? Now they've got nothing to do with the peripheral parts of the dentine pulp complex, so they don't enter the dentine. They're more closely, located inside, more centrally located. So they have a very central location inside the pulp, right? They move peripherally up to 100 to 200 microns into the dentine. And how do they move? Basically, they accompany the odontoblastic processes in the dental tubules, right? They are, of course, very important MCQ. They are lightly myelinated. The A delta fibers and the C fibers are absolutely unmyelinated, guys. Right? Now, this, of course, takes me to the next important MCQ. So we have one, we have second point, first, second. Okay. Next important point, guys, because they are lightly myelinated as compared to the unmyelinated C fibers, they have a faster rate of conduction of the action potential and they are slower, right? That's another MCQ. Next important point, the pain, the quality of the pain of A delta fiber is more sharp. Of C fiber, it's more dull, right? It's lancinating, right? Pricking, has an electric current like quality. All these are terms used to describe the pain which is generated when you stimulate the A delta nerve fiber, right? Sharp, lancinating, pricking, electric current like quality also, right? Then the pain of C fibers is dull, throbbing, pulsating, very severe, right? As compared to the C fibers, the pain of A delta fibers is relatively less severe or milder. Less severe, right? Um, then throbbing, pulsating, more severe, deep seated, more deep seated, excruciating, excruciating, deep seated, right? That's your basic points about the quality of the pain. Then the pain which is stimulated by A delta fibers is relatively short lasting, and the pain of C fibers is longer lasting. Right. Now, next important point, because the C fibers are more centrally located, that means that you have greater tissue injury. That means your carious lesion or your fracture has actually exposed the pulp, right? So it is more significant of a greater tissue injury, right? Severe inflammation like that found in a deep, very deep carious lesion causing irreversible pulpitis. So the pain of irreversible pulpitis is so bad because you've primarily, ended up stimulating the C fibers. Whereas the pain of A delta fibers does not represent tissue injury. It represents superficial caries, and it represents other stimuli which basically cause dentinal hypersensitivity. So this takes me to the next MCQ, guys, and that is the pain of dentinal hypersensitivity is carried by the A delta nerve fibers and not the C fibers. Right? Dentinal hypersensitivity is a situation which is represented by transient pain. Typical this kind of pain, right? Sharp, lancinating, short lasting, so on and so forth. It does not represent severe tissue injury. Right, guys? Next very important MCQ again is, before I miss that, is susceptibility to local anesthetics is more for C fiber than A delta, right? So seventh point is C fibers are more susceptible to local anesthetic, right? And the A delta fibers are less susceptible to local anesthetics, guys, right? Very important point. Another important point, that's my eighth point, that would be, think, C fibers are in general more sensitive to heat, stimulus than cold. And A delta fibers are more sensitive to cold than heat. Now, this does not mean that you cannot, stimulate the C fibers by cold, or you cannot stimulate the A delta fibers by heat, right? Both are susceptible to both, but more susceptible are the C fibers to heat and A delta to cold, right? So C fibers are more susceptible to heat, right? And the A delta fibers are more susceptible to, guys, all these points are actually important MCQs, more susceptible to cold stimulus. Right, guys? So that's the entire spectrum which I can think of that has been asked from the A delta and C fibers, guys. So we've done A beta fibers, we've done A delta fibers. Um, so there's this. Okay. So there's a doubt that has come that A delta fibers are more susceptible to local anesthesia than C fibers. That has to be checked. A delta fibers are definitely susceptible to local anesthesia because, I mean, both are susceptible, but which one is more? That has to be checked. I feel it's C fibers as far as my knowledge goes. I'll check this again, guys. One of you has raised this doubt. Good doubt. We'll check this. All right. Okay, great. I'll check this again. Okay. Now, guys, since we are doing this A delta and C fiber thing, we have to, before we move on to the pulpal sensitivity test, which is a very important component of this topic, we have to discuss dentinal hypersensitivity before we go further. So one is, guys, we have the first part of dentinal hypersensitivity is an image-based question which can come. What are the various stimuli that cause dentinal hypersensitivity? One is external pressure or dehydration, right? If you apply compressed air from your three-way syringe of your dental chair to the tooth, you're basically dehydrating the tooth, right? So drying or dehydration of the tooth by applying compressed air, that's one. Second is, of course, your thermal stimuli. So that would be cold temperature and heat. All right. Then the fourth would be your osmotic stimuli. Right? Your sugary foods. Right? So I have this section of, say, for example, dentine, right? A broad section of dentine, right? This is my patent dentinal tubule, right? And that's, of course, my deeper side, so that's my pulp, right? Then I've got my odontoblastic process. That's the cell nucleus and the extension of my odontoblast into the dental tubule, right? And accompanying this, as we just discussed, guys, is my A delta nerve fiber up to a distance of 100 to 200 micron into the dentine, right? Right, guys? Of course, my dentinal tubule is filled with, dentinal fluid, right? So I have my dentinal fluid. Now, first and foremost, guys, when I apply my dehydration or cold or osmotic stimuli, the direction of flow of the dentinal fluid is outward. All right. So for cold also, for dehydration also, and for osmotic stimuli, the direction of fluid movement is outward, right? And if I apply heat, guys, the direction of fluid movement is inward. Now, this is just a added information in the sense that you can get an image-based question in which they'll show you directions of where the pulp is, where the dentine is, and they can give you the direction of fluid movement. However, this is not going to make any difference to the concept of dentinal hypersensitivity. You understand? Because it's just that, you apply heat, the fluid expands, it's going to be pressed inside. The rest of the stimuli are going to kind of pull the fluid out towards the surface. Irrespective of that, This is just for your image-based question that you might get, say, an arrow pointing downwards towards the pulp, and they would ask you what kind of stimulus is applied so that the direction of the dentinal fluid movement is represented by this inward directed arrow. That is one image-based question. The second important point is, and that's it, there is no other relevance to the direction of fluid movement. The second most important point here is the theories of dentinal hypersensitivity, and that is your important MCQ, guys. So what is that? So there are primarily three theories that have been put forth. One is your odontoblastic transduction theory. They say that some kind of synapse is there which basically conducts action potential. That's more or less refuted, not very readily accepted. Then there is a neural theory that it's totally, you have your innervation, which is only the innervation, direct stimulation of the nerve fiber, the A delta nerve fiber is responsible. That again is refuted, guys, because your A delta nerve fiber is only present in the innermost part of the dentine, right? Adjacent to the pulp, right? Up to a distance of 100 to 200 micron. Your A delta nerve fiber is not traversing the entire length of the dentine, the entire thickness of the dentine. So if you have very superficial exposure of dentine and you're applying a stimulus, the neural theory again does not satisfy, right? So one MCQ is, of course, an MCQ of exclusion. All are theories of dentinal hypersensitivity except. All are theories of dentinal hypersensitivity except. So first of all, guys, you have to memorize the three theories, right? So you have the neural theory, you have the odontoblastic transduction theory, and you have the hydrodynamic theory, right? Now, guys, it's the hydrodynamic theory which is, of course, the most accepted. So that's one MCQ. MCQ, most well accepted theory of explaining dentinal hypersensitivity, given by next MCQ, given by Brandstrom. And as far as the question of exclusion is concerned, all are theories of dentinal hypersensitivity except. If you remember all these three, then of course whatever option is there in the fourth, that would be the answer, right? So that's another MCQ. That's done. And now next question is, what does hydrodynamic theory explain us? What does it say? It basically says that irrespective of the stimulus, and the other four possible stimuli, dehydration, cold heat, osmotic stimuli, whether the fluid movement is outward or inward, irrespective of that, when the fluid moves, then the A delta nerve fibers get irritated, voltage gated sodium channels open, and action potential is generated. The pain pathway is activated, guys, right? So the pain pathway is activated, and right at the level of the central nervous system, at the level of the cortex, there is perception of pain, right? What is that? What kind of pain that is? Of course, we've discussed those 8 points regarding the differences between the pain of A delta fibers and C fibers. So it's going to be short lasting because it's the pain carried by A delta fibers. Short lasting, knife like, lancinating, not very deep seated, not excruciating, mild, electric current like, and it would go on its own, go out on its own, go away on its own after a few seconds, right? So these are the questions that come from dentinal hypersensitivity basic. Next is the applied part, and that's a very hot and burning question, trending question these days. The AIMS people, the INI people asked this question a couple of years ago, and it's just kind of, it has, the controversy has kind of spiraled out of proportion, that lasers are used to manage dentinal hypersensitivity by which of the following mechanisms, right? So you have all these different kinds of questions like precipitation, different kinds of options like precipitation of colloids, um, blockage of action potential in C fibers, right? Then you have superficial. I'm telling you all the possible options that you can get. Superficial occlusion of dentinal tubules, then blockage of action potential in the pulp. Now, please realize there are two different options, guys. When I say blockage of action potential in C fibers and blockage of action potential in the dental pulp, I'll tell you what is the similarity and what is the difference, right? And then, of course, I have my golden option. That's my superficial occlusion of dentinal tubules, right? What else can you get? Obliteration of the dentinal tubules. That is another option. I'm telling you all possible scenarios. Obliteration of dentinal tubules, right? Then sealing of dentinal tubules, right? Right, guys? Now, guys, first of all, let us look at the facts. When I talk of dentinal hypersensitivity, it is attributed to A delta nerve fibers, not C fibers. You understand? It is attributed to A delta nerve fibers, not C fibers. So any option which is related to C fibers is going out of the window. That is not the answer. You understand? Right? That's one thing that has to be kept in mind. The other thing that has to be kept in mind is how do lasers act actually. So one is laser is what? Laser is basically nothing but a source of energy, right? And it basically heats up the tooth structure, right? It melts the tooth structure. And when it melts the tooth structure, so for example, if this is my situation, right? That's my block of dentine here. That's my dentine, right? That's my intertubular dentine. And that's, of course, my patent dentinal tubule, right? So if I'll represent this by red, by representing it by heat. So I'm to heat this with laser. This is going to melt, right? My intertubular dentine is going to melt and it will flow like lava up to a certain distance into the dentinal tubules and kind of occlude it, right? So this is one documented mechanism of my action of laser, superficial occlusion of dentinal tubules up to a depth of 4 micron, right? So up to a thickness or depth of 4 micron, superficial occlusion of dentinal tubules up to a depth of 4 micron happens. Now, if this is there directly, if this is there directly as one of the options, Guys, that's the answer. That's my golden answer, right? I mean, there is no doubt. If you find this term, and I hope in the exam, because this is a direct pick from Cohen, if the examiner, is, following the textbook and not following, the distorted recall versions of these questions, and is following the original question, then I think this should be there as one of the options. Exactly this line. Either not necessarily, going up to the depth of 4 micron, but at least a superficial occlusion of dental tubules, right? That's my golden answer. Next important thing that has been seen that lasers do is that they block the action potential, the generation of action potential in the C fibers. That's one thing, right? Now, this cannot be the answer because dentinal hypersensitivity is not attributed to C fibers. Cohen writes another line. Cohen writes that there is blockage of action potential of nerve fibers, not necessarily C fibers, of nerve fibers in the dental pulp. Right, guys? Now, please realize that these A delta fibers, which are coming, extending into the dentine, are basically coming from where? From your CNS, right? Somatosensory cortex, right? Right, they're the afferent fibers, right? And they're entering the tooth finally through the apical foramen, right? Through the apical foramen, traversing the pulp, and then finally ending in the dentine, right? So, when I say, guys, listen to this carefully, guys. When I say, when Cohen says that blockage of action potential of the nerve fiber, they're not necessarily C fibers, in Yeah, guys. So now I'm audible. Now, am I audible, guys? Just give me a thumbs up. Thumbs up if I'm audible now. Checking the group also. Okay, great. So I'm going to repeat this last point, guys, just in case you missed because of voice issues, voice broadcast issues. Yeah. So, guys, I was talking about this best possible answer for the mechanism of lasers acting to manage or treat dentinal hypersensitivity. Guys, as I said, the best answer is if you find this superficial occlusion of dentinal tubules, right? And this is like a short form of the full statement given in Cohen, that's superficial occlusion of dental tubules up to 4 micron. Then comes the controversy. Now, this is not controversial. This is my star mark best possible answer. The second important thing about lasers, which is true, that it blocks the action potential generated in the C fibers. But this cannot be the answer. Why? Because dental hypersensitivity is attributed to A delta nerve fibers and not C fibers, guys. Right? All right. There's another statement about lasers that is a general statement that it blocks the action potential generation of nerve fibers in the dental pulp. Now, guys, please realize that yes, C fibers are restricted to the dental pulp, not traversing to the dentine. A delta fibers traverse to the dentine, but of course, where are they coming from? They're coming from the somatosensory cortex, from the thalamus, across the thalamus, going across the trigeminal nucleus through the middle cranial fossa, entering the apical foramen, passing the pulp, and then entering up to certain distance, giving company, being friends with the odontoblastic process and traversing 100 to 200 micron of the thickness of dentine. But they're coming through the pulp, right? So if you get a general statement that there is blockage, lasers act to manage dentinal hypersensitivity by blocking the action potential of the nerve fibers of the dental pulp, then this is not a wrong statement, because when you generally say of the nerve fibers of the dental pulp, you include A delta fibers as well, guys. So please be very careful. My best answer is superficial occlusion of dental tubules, blockage of action potential of the C fibers cannot be the answer to this, but if you do not have superficial occlusion of dental tubules as one of the options, but if you have this statement as one of the options, blockage of action potential of nerve fibers, and not necessarily mentioning C fibers, in general nerve fibers in the dental pulp, then this is my second best answer, guys. Right. So we have to see the question very, very carefully, guys. Right? Yes. All right, excellent. So that's precipitation of colloids is not a good answer for laser. Precipitation of colloids is a good answer for something like a gluma desensitizer. That's basically a specific product which is a, you can say, a next generation varnish. Earlier varnishes used to be there to seal the dentinal tubules. So for varnish, the mechanism is sealing the dentinal tubules, right? For gluma, it would be more of precipitation of colloids or proteins or colloids in the dentinal tubules. But for lasers, these are my best answers, right, guys? Excellent. Right. So this was all about the basics, the nerve fibers, the applied part of the nerve fibers, and then I move on to the, you can say, the core part of this chapter. We were somewhere in the periphery, but of course, guys, each and every word that I said here, I feel is important from your MCQ perspective. Now I'm going to be talking about the pulpal sensitivity tests, guys. Now, first of all, pulpal sensitivity tests are also known as pulpal sensibility tests, right? That's one thing. Next important thing is that they are not true pulp vitality tests. They are indirect tests of pulp vitality. So they are not true pulp vitality tests. That's your MCQ, guys. Why? Because they are not directly assessing, or measuring the pulpal blood flow. They are just checking their sensibility or sensitivity. Why? Because they are checking or determining whether the innervation is intact or not. So they give you a fair idea of whether your pulp is vital or not by indirectly checking whether your A delta and C fibers are functioning or not. Because usually, I mean, if in a necrotic tooth, they won't function. Just an added MCQ, because I've used the word usually. Why? You will ask me, sir, why? I mean, in a necrotic tooth, of course, they should not function, A delta and C fibers. So very important MCQ, guys. C fibers are resistant to prolonged periods of anoxia. So basically, some of the C fibers will keep firing for some period, even in a necrotic tooth. So that's your MCQ. C fibers are resistant to prolonged periods of anoxia, right? So always say, guys, when you're doing RCT of even of a non-vital tooth, if you want adequate patient comfort and if you want to do good treatment, give local anesthesia, right? Many people say, don't give local anesthesia. This is a non-vital tooth. You're causing pain to the patient. I mean, come on. Local anesthesia is supposed to be administered, guys. If you read Sturdivant, you're supposed to give local anesthesia even while you're doing class 1 and class 2 cavity preps. We don't follow it. Very conveniently, we say, oh, that's all theory. I mean, come on, these are practical textbooks, right? If you read Sturdivant, it's a full manual of operative dentistry. It's very easy to say, no, don't give local anesthesia. It's very wrong, right? Supposed to give local anesthesia. Yes, for operative dentistry, it's okay. I mean, some level of dentinal hypersensitivity while you're moving the burr is okay. But I mean, come on, when you're doing a root canal treatment and already thinking, oh, this is necrotic, oh, this is totally necrotic, no point in giving local anesthesia, and the patient jumps and then he asks you, doctor, what are you doing? I did not refuse for local anesthesia. I would have been very happy to get a shot of local anesthesia and then be comfortable for the rest 40-45 minutes during my entire appointment. I did not say no to you. Why did not you give me local anesthesia? What will you say? I was not confident enough of giving local anesthesia. My inferior alveolar nerve blocks don't work. So guys, do the right thing, right? Yes, practical things are sometimes slightly different than theory, but I mean, at least try to do the right thing, isn't it? Okay. So C fibers are resistant to prolonged periods of anoxia. You're doing root canal treatment, instrumentation in a non-vital tooth, supposedly non-vital tooth. Sometimes there's pain, right? And a lot of pain. All right. So coming back, what all are the pulpal sensitivity or sensibility tests? So primarily we have thermal and we have the electric pulp test, EPT or the EPT. Very favorite as an IBQ, image-based question, right? Very common in the previous 2-3 years. Okay, so thermal tests, guys, we have both the heat test and the cold test. The first and foremost thing, heat test is not a good test, right? So then why are we discussing it? What is the indication? The indication is very clear cut. If the patient says, gives you a history that I have pain on taking hot beverages, so then based on the patient's history, you're supposed to do a heat test. It's as simple as that, just to recreate that condition and to confirm that, okay, fine, the patient does have pain on taking hot beverages, and let me confirm that. It is not a good test, not a good test, and not supposed to be done routinely. Why? Very important, guys. It has a very high chance of giving you false positive response. Now, what do we mean by false positive response? Means the response is positive, means the patient is raising his hand, yes, I have pain. So you have diagnosed the tooth as being vital, right? However, it is false. That means the tooth is non-vital. So a false positive response to a vitality test is a non-vital tooth being incorrectly diagnosed as being vital. Right, guys? What are the reasons? One is, of course, the presence of C fibers, and I told you before that C fibers are more sensitive to heat than cold. So even in a necrotic tooth, because C fibers sometimes sustain or survive for prolonged periods of time, even in the presence of anoxia, they might get stimulated by the heat. That's one. But the more important reason is, guys, I have a necrotic tooth. MCQ, guys. The moment the tooth becomes necrotic in the next 3 weeks, this tooth pulp, the entire root canal system, is going to be completely colonized with bacteria, right? Now, bacteria, and primarily, when we do endodontic microbiology, I'll tell you there that basically in a primary endodontic infection, right, most of the bacteria are anaerobic, right? Now, these bacteria are going to undergo glycolysis, right? They're going to eat up the sugars, they're going to undergo glycolysis, and they're going to release acids, right? Pyruvic acid in gaseous form, lactic acid in gaseous form. When you apply heat, when I apply heat to the test during heat testing, these gases are going to expand, guys, and they're going to move into the PDL, and PDL is a highly innervated structure. So this patient is going to complain of pain upon application of heat, right? So this is a necrotic tooth, and you have incorrectly diagnosed it as vital. So that's why heat test is not a good test, guys. That's why heat test is not a good test, right? All right. Next very important concept from the heat test and very important MCQ is that when you are doing a heat test, do not apply the stimulus for more than 5 seconds. Even if the patient has not raised his hand, don't keep on waiting for the patient to raise his hand. Why? Heat test not to be applied for more than 5 seconds. Why? Because it causes biphasic stimulation of C fibers. Now, what do I mean by this, guys? Guys, basically what happens is that, say for example, I have a normal case, very superficial caries, not deep caries, and I apply my heat test for more than 5 seconds. So what happens is that initially, my peripheral A delta nerve fibers get stimulated, right? But if I keep on applying my heat test for a time greater than 5 seconds, secondarily, my C fibers are going to get stimulated. And the C fiber stimulation, despite the fact that the caries is not deep, there is no pulp exposure, there's a good amount of remaining dentine thickness between the defect, whatever that defect is, abrasion, attrition, caries, trauma, whatever. Despite that, if I apply my heat for greater than 5 seconds, my C fibers also get stimulated. And that would give rise to excruciating, deep-seated throbbing pain. And that would incorrectly diagnose a case of simple reversible pulpitis or dentinal hypersensitivity to symptomatic irreversible pulpitis. So that's the second drawback. So one is the drawback of false positive. The other is the drawback of biphasic stimulation of C fibers, in which there is overestimation of the disease, right? A reversible pulpitis or a dentinal hypersensitivity is getting incorrectly diagnosed as symptomatic irreversible pulpitis, guys. Right? Yes. So that was the important conceptual questions from the heat test. Now let us talk about some theory. In general, you can apply your heat test with a hot, stainless steel instrument like a hot ball burnisher. You can use warm water. You can isolate your tooth with rubber dam, use warm water. You can generate frictional heat with the help of your polishing abrasive discs. Again, it is not recommended, because even when you have to do a heat test, never generate frictional heat by abrasive discs, because this can generate uncontrolled amount of heat, right guys? Then you can use a warm thermoplasticized katta parcha cone. So these are the various ways in which you can generate heat. These are classic questions. Nowadays do not come. Nowadays these applied questions come, guys. Now, before I discuss another controversial question, I'm going to first discuss the cold test, and then I'm going to come to the controversial question. Now, what is a cold test? Cold test is you're applying cold stimulus, right? So what are the various ways in which you're applying cold stimulus, guys? One is you can use cold water. Again, isolate the tooth with rubber dam, use cold water. You can use ice sticks. You can use carbon dioxide snow, also known as dry ice. The MCQ is, what is the temperature? The temperature range is somewhere between minus 56 degrees Celsius to around minus 96 or minus 98 degrees Celsius, and the average would be somewhere around minus 78 degrees Celsius. Now, this is intense coolness, right? So you can actually do a successful cold test on a full coverage crown. You have a tooth which has a full coverage crown. You can apply this carbon dioxide snow, and you can expect a positive response, because that level of intense coolness traverses the thickness of the crown and cools the tooth. Right? You can use 1112 tetrafluoroethane. The MCQ is temperature, that's around minus 26 degrees Celsius, right? You can use refrigerant sprays, which are basically a collection of hydrocarbons like butanes, right? No need to remember the temperature. Then you can use ethyl chloride spray. That's also basically a hydrocarbon only, which volatilizes. You apply it, kind of evaporates, leaving the tooth structure very cool. The ethyl chloride spray right, guys? Um, yeah, the MCQ with carbon dioxide snow is that you can use it successfully with a tooth with restored with full coverage crown, right, guys? Yes. um all right, now comes a very important question, guys. Clinical based question, because we've done heat and cold test. First of all, of course, cold test is always better than the heat test because the chances of false positives and other false results are less. It's the very good test of pulpal vitality. You get a positive response to cold test, most of the times the pulp is vital, right? That's one. Next important MCQ here is, guys, that if there's a statement in Cohen which says, a patient says that my pain aggravates on taking hot beverages or hot food, and it is relieved by cold or by taking ice cold water or by keeping an ice pack. What is the diagnosis? Guys, the diagnosis is necrosis, pulpal necrosis. That's what Cohen says. So statement is, I'll tell you where the controversy is. The statement is pain aggravates or increases on taking hot food or liquid, and the pain is relieved. The pain is relieved on taking ice cold water or keeping an ice pack corresponding to the area or the tooth that is causing pain. Diagnosis, question mark. Answer is pulpal necrosis. Right? Of course, I just discussed, this is right. I just discussed that in a necrotic tooth full of bacteria, which is releasing acids in the form of gases, some liquids and gases, you apply heat, the gases expand, move into the PDL, and cause pain, right? Because the PDL, even in a necrotic tooth, is innervated, right? If you apply cold, the gases would contract and there would be sudden relief in pain. So the diagnosis is pulpal necrosis. The controversy here is, guys, this diagram or image-based question in Cohen, this is a similar situation. But this guy, this gentleman, is basically sitting outside in the waiting area of the dental OPD with an ice pack or a ice water filled jar against the painful area, right? And Cohen writes, so Cohen in the theory part writes pulpal necrosis. Here Cohen writes that this guy is suffering from irreversible pulpitis. Now the thing is, what will you mark when this question comes in the examination? Guys, when it comes as an entire statement, I'm going to see the answer is pulpal necrosis. Now I'll tell you why sometimes a pulpal necrosis is incorrectly diagnosed as an irreversible pulpitis. This happens in molars, in multi-rooted teeth, where some remnant of a vital pulp is remaining in one of the canals. So for all practical purposes, your pulp chamber, that's your coronal pulp, is necrotic. Your 2 out of 3 canals are having a completely necrotic pulp inside them. In one of the canals, say a mesiolingual canal or a mesiobuccal canal of a lower molar, some remnant of vital pulp tissue is remaining, and you do some test like an electric pulp test or whatever, a cold test, and the patient gives you a response that is attributed to that vital pulp remaining, right? So that tooth is kind of diagnosed. I would not say incorrectly diagnosed, but yes, for all practical purposes, incorrectly diagnosed as irreversible pulpitis, having a vital pulp, right? So, guys, both the statements are correct in that context, right? Basically, you're dealing with a situation in which you cannot take the pulp back to health. You have to do a RCT. As far as treatment is concerned, no difference. As far as diagnosis is concerned, yes, one will say it's necrosis, one will say it's partial pulpal necrosis, one will say it's irreversible pulpitis or whatever. The thing is, what do you do in the exam? We've understood the concept, we've understood why there is a controversy. What do you do in the exam? I would say in the exam, in all likelihood, it should happen that if you have this image-based question in which, see, if you see the line underneath, guys, see the line underneath. Patient has found that the only way to alleviate the pain is to place a jar filled with ice water, right? Now, I would say, guys, that if the question comes as an image-based question or and, there's no complete line where he's saying that there is pain increasing on heat or hot temperature, which is being relieved by cold. If he's simply saying that the pain is relieved, this is an image-based question, and the pain is relieved by keeping cold temperature, right? So a source of cold temperature against the jaw or the cheek, then better mark irreversible pulpitis. If there's a full statement, it's literally on the same page of Cohen, where in theory part it's written pulpal necrosis, in the image it's written irreversible pulpitis. So I would say, we go with Cohen. And if it's not an image-based question and it's completely, the entire statement is written that the pain increases on heat, decreases on cold, right? Pulpal necrosis, right? We have conceptually understood it, but as far as MCQ is concerned, I would say you follow this, right, guys? Excellent. This brings me to the third part of the pulpal sensitivity test, and equally important, rather more important, and that is my electric pulp test, guys. Right? Now, guys, electric pulp test is basically relying on, what does it rely on again? It basically relies on direct stimulation. You generate electricity, right? So here you're not relying on the movement of the dentinal fluid, which is then causing the generation of action potential in the A delta nerve fiber. Here, the EPT is relying on direct stimulation, or in other words, direct generation of action potential in the direct stimulation of the A delta nerve fibers. Right? That's one. That's first MCQ. In general, that is what EPT does. I mean, of course, you can't be that sadistic, yeah, where there's an exposed pulp and you're putting that electrode on the exposed pulp to directly stimulate the C fibers. That doesn't happen, right? We never do that. So that's why we say that it's direct stimulation of the A delta nerve fibers, right? The other important thing is, guys, of course, you get a image-based question always. It's a very favorite of the examiner, and big favorite of the examiner. I'll just show this image to you guys. It's very important, guys. Even if I have to see the net, I want to show this image to you people. Electric pulp test. Yeah, so this is how it looks like, and this is a classical image in which there will be a tooth, and this electrode tip here would be coated with, or the tooth surface would be coated with a toothpaste, like electrolyte, and they would ask you to identify the device, and the answer would be EPT. Very favorite with the examiner, guys, right? All right, coming back, so that's one part. Next important part of the MCQ here is, yes, All right. So IBQ you get image based question. Next important part is questions. What's this? What is this topic? Why is schedule? Okay. Also check the YouTube link. What are you guys doing? The YouTube link of getting a phone. Just a sec, guys. Yes, guys. Yeah. I'll just check the link in the. I hope I'm audible. I'll also check the link in the Telegram group. This. ये YouTube का लिंक. Sir. Yeah. Am I live? Yes, guys. So we were talking about the electric pulp test. The IBQ is done. Yes. Next important point is what is the area of placement? That's another very important point. What is the area of placement of the electrode, guys? Where do you place the electrode? Right. Now, as far as anterior teeth are concerned, basically the idea is that you have to place the electrode tip in the area of maximum innervation, right, to get the best possible result. So in anterior teeth, guys, we place the electrode in the, so I'll make a diagram for better understanding, in the incisal 1/3 or the incisal edge, because that's the area corresponding to the pulpal horn in the anterior teeth. So the incisal 1/3 or the incisal edge. Of course, you should not be getting both these options as separate options. Both are correct, right? Then very important, guys. What about the posteriors? Now, when you say in general for posterior teeth, in general for posterior teeth, guys, the answer is middle third of the buccal surface of the crown. However, specifically for molars, it's the mesiobuccal cusp tip. So if they ask you where do you place your electrode tip for molar, it's the mesiobuccal cusp tip for molars. That's your MCQ. But in general, for posterior, it's the middle third of the buccal surface, right, guys? That's how it is. That's how you're supposed to answer. That's my conclusion from various things that are written in your textbook, right? Then, with EPT, we have got applied MCQs now, and that is, what are the situations in which you get false positive responses, and what are the situations in which you get false negative responses, right? So let's be very simple here, conceptual. Positive, false positive is you get a positive response. That means you've incorrectly diagnosed the tooth as vital, whereas it is false, right? So you diagnose the tooth as vital, but it's false, meaning a non-vital tooth. So basically, you're dealing with a non-vital tooth, and you've incorrectly diagnosed this as positive, right? So when does that happen? When you're dealing with a very anxious patient, right? Who's jumping on the chair, right? Then when you've placed your electrode of the EPT, right, on a metallic restoration, or the electrode has been placed on the soft tissue, which is of course lined by which is conducting the electric current, right? This is giving you a closed circuit, right? Then you get a false positive response in a case in which there is liquefactive necrosis, basically abscess inside the pulp, liquefactive necrosis, right? So that abscess or that tissue fluid exudate inside the necrotic root canal becomes a medium of conduction of electric current, right? Then, of course, again, you have a multi-rooted tooth in which one of the canals has got some vital pulp tissue, otherwise the entire root and the entire pulp chamber is necrotic, and you can incorrectly get a positive response. So all these are reasons for false positive. Now, this is a very important, I'll star mark this, guys, very important kind of an MCQ. You have to, if you remember this conceptually, you will be able to solve the problem. So the question would come like all our situations of false positive response on an EPT except. So if you know all these points, you'll be able to get to the right answer. And what is the situation with false negative, guys? Meaning you get a negative response. That means you've you've diagnosed the tooth as non-vital, but it is a false response, meaning you're dealing with a vital tooth, but you've incorrectly diagnosed it as non-vital, right? So a classic situation is a recently erupted tooth with blunderbuss canal or open apex, right? So what happens, guys, is usually what happens is that imagine it's an 80-year-old boy or girl, you're checking the upper central incisor and you're doing an EPT, right, guys? What happens is that usually the vasculature of the dental pulp develops first and innervation follows. Innervation takes some more time to develop, right? So when you're relying on your EPT to directly stimulate the A delta nerve fiber in a young permanent tooth, you might incorrectly diagnose it as being non-vital where the tooth is perfectly fine, right? Then next situation is recently traumatized tooth. recently traumatized tooth. So in this situation also, of course, there are certain details which we are going to discuss in great detail during endodontic traumatology, but in a recently traumatized tooth, guys, basically there's damage, whether it's a subluxation injury, whether it's an extrusive luxation, some root fracture, whatever, some trauma to the tooth. There is um, stunning, what is known as damage to the apical neurovascular bundle. And the innervation is stunned, meaning the pulp is still vital, right? The trauma is not that severe, but because of the trauma, the nerve, even on stimulation, is not able to generate the action potential. So for a few months, for several months, you can keep testing it and you can get a negative response, whereas the tooth is perfectly fine in terms of being vital. Right. Then, of course, you have a situation in which the patient is heavily sedated, right, or under the influence of alcohol, right? So heavily sedated or under the influence of alcohol, guys, again, you can have a situation where, the patient is like not in his senses and he's saying, guys, I don't have any pain, even when you're increasing the stimulus. Right, guys? And that was about the classic tests and all the possible MCQs that come here. Then, when we talk of the true pulp vitality tests, guys, I don't want you to go too much into the details. Just remember the enumeration, the various true pulp vitality tests. One is laser Doppler flow meter. So it basically measures the velocity with which your RBCs are moving. So RBCs are only moving when you have vasculature, so when the tooth is vital, right? So usually you use a light of a wavelength of around 632.5 nanometer or 635 nanometer, right? Then we have pulse oximeter, which again is basically measuring the the absorption characteristics of oxyhemoglobin and deoxyhemoglobin, right? And based on that, certain values are generated, right? So you basically make incident a light in the red region and in the infrared region, and oxyhemoglobin and deoxyhemoglobin are going to absorb light with different properties, right? So oxyhemoglobin is going to absorb some amount of red light, some amount of infrared light. Similarly, deoxyhemoglobin is going to have its own properties, own spectral properties based on its chemical constitution, right? So they're going to absorb some light, they're going to let some light pass by. You're going to have a receptor on the other hand, like a pulse oximeter, right, which you used to put in our fingers. So there's one is the source, one end is the source of light, the other end is the receiver of that information, right, of the wavelength of the light. And then you're basically going to tabulate the ratio of the intensities of the light that you've received on the receiver, and based on that you can figure out how much, whether this tissue has got any oxyhemoglobin or not, right? So based on that you can determine whether the tissue is vital or not. And another MCQ that comes is, it is based on Beer-Lambert law, right? You don't have to memorize the wavelengths. Then we have, similar to this, dual wavelength spectrophotometry, guys, right? Again, no need to go into too much details. Then we have what is known as cholesterol crystals. Now, what is that, guys? What is cholesterol crystals? So basically, these cholesterol crystals, as the word suggests, these are crystals of cholesterol, right? They have this property of changing color at different temperatures. So for example, at 30 degrees Celsius, the cholesterol crystals are, say, just for example, you don't have to memorize this, orange color. And when you increase the temperature to 37 degrees Celsius, it becomes, say, for example, green color. Just giving an example, right? Now, in general, a non-vital tooth will be cooler. it won't reach 37 degrees Celsius. A vital tooth which has got blood supply has greater chances of reaching 37 degrees Celsius when it is cooled. So it's going to rewarm faster. So you apply cholesterol crystals on the surface of the tooth and you see the color changes, right? Now, based on laboratory data, you know that at 37 degrees Celsius, this is going to be the color. So when you say, for example, you cool the tooth by, by your syringe or by pouring cold water on it in a rubber dam isolated tooth, and then you place cholesterol crystal and you realize there's a color change, and that color change matches to that color which comes, which appears, say for example, green color, which appears when the tooth rewarms at 37 degrees Celsius, you can predictably say with some level of confidence that this tooth is vital, right? So cholesterol crystals, of course, it's a very subjective method, not a very foolproof method. So it's used sometimes, but not very widely used because, as I said, there's not much objectivity in it, right, guys? So these are the various things and MCQs that come from this important topic of pulpal diagnosis, endodontic diagnosis. Yes, guys. Chalo, great, guys. So I think we've had too much of great, much detailed discussion. Whenever I start a new subject, initial couple of classes, I generally go a bit slow so that you get warmed up to the idea of that subject. We develop some concepts and then, of course, we can accelerate. Right, guys? So it's almost 7:15. We take a short break, right? It's almost more than about to be 2 hours, right? Oh, many of you have been asking for break. All right, guys. Okay, fine. So as you say, we take a break about what, 15-20 minutes. Have some tea, water, roam around, and then we come back and we meet again, right, guys? Sure. Thank you, guys. See you. We'll take a short break.